how to be the first assistant for insertion of a pacemaker. So when you're preparing to be the assistant to the primary operator, it's important to get all of your equipment ready. You will want to have the actual pacemaker box. In this case, this is an external pacemaker box that is capable of doing both atrial and ventricular pacing. Number two, you will have the actual connecting cable that connects the pacemaker box to the actual pacing catheter. There is a red colored adapters that are required to connect this cable to the actual pacing catheter. And as you can see, the physician has the pacing catheter already ready to go on the table. What we're going to do next is we are going to connect the wire into the V portion of the box. We, in this case, are only going to be doing ventricular pacing. So we'll ensure that it is connected and working properly. And then what we can do is we can prepare to turn the pacing box on, which we can do first, and we'll do the settings afterwards. Now we can have the pacing box ready, and we're going to now get the physician to pass the distal end of the pacing catheter to the assistant. And the first thing that we will do after that is to do a balloon test. So once the physician passes over the pacing catheter and the syringe for the pacing balloon, you will take the syringe and put it on the balloon port of the catheter, and you can lock it on. There is also a lock on it that can be opened and closed that will allow you to actually move air in. And when the physician is ready, he or she will ask for a balloon test. And so when we do a balloon test, go ahead. You will insert 1 cc of air into the syringe. And as you can see, this balloon has not ruptured, which means that this balloon is ready to go. We will now remove the air from the balloon because the initial insertion is done with balloon down. Next, we're going to get the rest of this catheter ready to go. So we're going to take the two black ends of the catheter, and we need to insert the red colored adapters as such. Once we insert the two red colored adapters, you will then use the positive to the plus side of the wire that comes out of the pacing box. And so once that is inserted, you turn the red colored knob, which screws it in and makes sure that it cannot be removed. And same thing with the negative post, you will insert it into the other end of the wire. Once it is tightened and cannot be removed, we will then prepare for pacing. Usually, the primary operator will tell you a setting to use. Most of the time, this will be in a VOO mode. What this means is that we are pacing the ventricle. We are not sensing the ventricle, in other words, the first O. And the third letter means that we're not doing anything if we sense something. In other words, this is fixed pacing. You typically will want to choose a rate that is faster than the patient's intrinsic rate. So in this case, because this patient is in third degree heart block at approximately 30 beats per minute, we will use maybe a pacing rate of 80 beats per minute. And so increasing that rate once pressing the unlock button on the pacer. And also, we will need to increase the threshold. The threshold is the amount of electrical output that the pacer gives. We want to have a very high output, so we'll go up to 25 millivolts so that we make sure that when we go in, that we are ready to capture. So you would like to verbalize the settings that you're on at this time to your primary operator.
Rate of 80, output of 25 on VOO.
Perfect. And so now the primary operator will insert the catheter. What they will first do is they will put the sheath over the catheter, which will make sure that it is sterile. It is very important to put the sheath in the correct direction. This is a common area of mistake during catheter insertions. You want to have the portion of the sheath that actually attaches to the cordis going in the direction away from the pacemaker. So I'll get you to insert that. And then this sheath should be moved all the way towards the distal end of the catheter so that you have lots of room to work with. This sheath will end up being non-sterile. Once the primary operator does that, he or she will insert the catheter into the back end of the cordis, again ensuring that the angulation of the catheter is towards the heart. He will also remove the initial sterile cap, the blue cap, which he just did. And now he will insert the catheter to approximately 15 centimeters. There are hash marks on all of these catheters at every 10 centimeters. By going down to 15 centimeters, so again, he'll go past the first hash and towards between the first and second hash, even 20 centimeters is fine. Once you get beyond 15 centimeters, the distal end of the catheter is beyond the distal end of the cordis, which means it is now safe to put the balloon up. The primary operator will ask the primary assistant to put balloon up.
Balloon up.
And you will
Balloon
put 1
up.
cc of air into the syringe, and will also verbalize the fact that you have done this, which now allows the catheter to move in the direction of blood flow, also known as a Swan-Ganz. So now the primary operator will push the catheter down while watching the monitor to see that it converts from third-degree heart block to a ventricular paced rhythm. It is also good, because it is difficult to do both things if you're the primary assistant, to say if there's a rhythm change. But as he slowly advances the catheter, we will look to see if there's a change to ventricular pacing, which will be a wide, complex, left bundle branch block type pattern with a pacing spike before. This will typically occur between 30 and 40 centimeters. So as you can see, we have now had a rhythm change to a ventricular paced rhythm with pacing spikes at 80 beats per minute, suggesting that the catheter is now ideally in the right ventricular apex. At this point, the primary operator will usually ask you to put the balloon down.
Balloon down.
And we will make sure that once the air is taken out of the balloon, that the catheter has not moved, and this will be determined by remaining in ventricular pacing, as you can see. At this point, we're typically happy with the position of the catheter, and so you can lock the air-filled portion of the catheter as the first assistant, so that there's no chance of the balloon going up accidentally and removing the syringe, but making sure that you keep the syringe close by or either on the catheter so that it is available to you. Once we do this, the primary operator will put the sheath and connect it to the cordis, as you can see. This will then allow for there to be a non-sterile section where you can actually manipulate the catheter later on once you have all gloves off and so on. The final step will be the threshold test. The primary operator will typically ask you, while watching the monitor, to slowly reduce the output of the pacemaker. This is done by first pressing the unlock button on the pacemaker box. And once you press the pacemaker lock button, you will reduce the output, typically by 1 millivolt per every 3 beats. Because we're starting at 25 millivolts, we can rapidly go down to approximately 5 millivolts while ensuring that the patient actually has a rhythm. And so as you can see, despite going down on the actual output, there still is pacing. Typically a good output is 0.2, 0.3 millivolts for a threshold. Now that we're at 5 millivolts, we're going to want to go much slower. So we'll go down by 1 millivolt after every 3 beats. So let's go to 4. Now let's go to 3 millivolts. Let's go to 2 millivolts. Let's go to 1.5 millivolts. Let's go to 1 millivolt, and as you can see, we still have pacing, which means we're capturing. Let's go to 0.8 millivolts. And as you can see, at 0.8 millivolts, we have had a change in rhythm, which means that we're no longer capturing. We will now increase the threshold back up to typically 3 times the threshold. The threshold in this case was 1 millivolt, so let's increase to 3 millivolts. And as you can see, as you're increasing beyond that threshold of 1 millivolt, pacing resumes, and that tells you that you're now capturing the ventricle. Typically, a safe pacing threshold is 3 times the threshold. So in this case, the last output that we had sufficient pacing was at 1 millivolt. So we want, that is the threshold is 1 millivolt. We want to at least be 3 above it. For external pacemakers, because we're not worried about battery life, you can even go to 5. So in this case, let's leave the pacemaker at 5 millivolts. And so once you're at 5 millivolts, you can see that the patient is appropriately pacing. It is important to document the depth at which the catheter is, to document what the threshold is, and a pacing threshold test is typically done daily to see if there's a big change in the pacing threshold, because if there is a big change in the pacing threshold, it suggests that the catheter may have potentially moved.